Thank you, Martin. Oh, look at the lights. Well, good morning, good afternoon. It's afternoon, isn't it? Yeah. Everyone, thank you very much. It's a pleasure to be here. This is the third time, I think, that I've been here. And I know you're all hungry, so I'm going to speak clearly but quickly. I'm going to share a few things with you this weekend. The first is around applied biomechanics and some work that we're doing in Vancouver to integrate biomechanics with clinical practice. So a dream many years ago, about 7 years when I got involved, was to build a center, an athlete development center in Vancouver that integrated all the sport medicine professions, allied healthcare professionals, and brought science into the picture. And it's very interesting because traditionally scientists have worked in silos, often in laboratories at universities. Very few individuals would ever actually get into that lab unless they were a subject in a study. And the dream for us really was to bridge the gap between clinical practice and science and research, and to make what we do in the biomechanics lab accessible to everybody, whether you're an elite athlete or whether your goal in life is to walk your dog 3 times a week. And so this lab that I'm going to show you today and some of the case studies that we've done has really been purpose-built to bring applied biomechanics to the public. And so within our institute we have sport medicine physicians, podiatry, massage, physio, chiropractic, podorthics, and then we have that integrated with the human performance lab, which in itself has biomechanics integrated with physiology. So it's kind of a neat place to work. So I just want to share some of that with you today. And very similar to Trevor's presentation, I'm going to talk a little bit about how we take quantitative biomechanics and make it clinically relevant. And I think that that's the key point. With each client who comes to see us, it doesn't make any sense for me to hand out a bunch of numbers and graphs to a collaborating healthcare professional. It doesn't make any sense to give a bunch of graphs to a client. So the interpretation piece is the key. So our lab is about 3,000 square feet, and as I mentioned, it's not just biomechanics, it's also physiology. We have a 10-camera qualysis system. So we wanted to set it up so that we could provide day-to-day analyses or services to clients, but also have it set up and all the code written so that we could do rigorous research as well. So our mandate really is to provide service and make it accessible to the community. It's to perform a rigorous research program and also to work with industry partners for research and development purposes. So what you'll see here is one section of the lab, and really the only dedicated section of the lab, where we have 8 cameras set up, and we look primarily at locomotion, walkers, and runners. And in the center of that volume, you'll see a treadmill, and it's an instrumented treadmill that was actually prototyped and designed by one of my classmates at UMass Amherst. And it measures 3-dimensional forces continuously while the cameras measure motion. And you synchronize those 2 signals so that you can calculate resultant joint moments and do the kinetic side of things as well. And I think what we've really learned in the last 10 to 15 years is how important the forces are. And the mechanism of injury can often be best described by looking in depth at what's happening at the joint level in all 3 planes. So this is a 3-dimensional system, what you typically see in the university, and we're trying to make it accessible to everyone. So we had to kind of build it from scratch, and we wanted to build it so that we were able to have all the code written, do all the calculations, everything in the background set up so we can do research projects, and those that can be submitted to peer-reviewed journals, high-end, but also be able to spit out and process information quickly so that we can follow up with the client. So we really focused on 3 areas in the first year. One was around a 3D run analysis and a 3D walk, and just recently a 3D jump analysis, which is really about screening for ACL potential injury. With the treadmill, it's kind of nice because you can measure the forces continuously, and many of you and I have talked before about coupling patterns and looking at coordination patterns over time. So this allows you to look at many successive footfalls And you can look at a number of different conditions. So you can adjust it for speed or incline. We look at a number of different conditions, whether they're footwear conditions. We can look at uphill running, downhill running. We look at different types of braces, which has been interesting, and also we can do it over longer durations. Many clients and runners will come in and tell you that, my knee starts hurting at minute 14 of my run, and so we try to create the most ecological conditions we can, duplicating what happens naturally to them. So we do the run, and the walk is very similar. However, we often use the multi-segment foot model, the Oxford foot model, to try to get more information about what's happening at the level of the foot and within the foot. And this has been a fantastic tool for us. We'll use this in conjunction with shod capture, so when they're running in their shoe. But as you all know well enough, there's a lot of great information that's lost inside the shoe when you're doing traditional video capture, because you put markers on the shoe. And we've played around with different running sandals and whatnot, but still we don't get the great information that we can from this multi-segment foot model. So we'll often look at somebody walking, then running, and put it all together. And then more recently we've added jumping analyses. So I work with a lot of physiotherapists who are interested in ACL injury prevention, and particularly non-contact ACL. And this is also great for lateral ankle, chronic ankle instability and other questions as well. So these are a number of different jumping tasks to look at, single leg hops and squats, drop vertical jumps, that type of thing. And the next thing that's on the horizon is cycling and developing a 3D cycling analysis. And here's just an example of the jumping protocol that we use. It's well established in the literature that people who have a risk of ACL injury exhibit certain knee dynamics upon landing. And so we're able to quantify that, both the kinematics and the kinetics. So we have the quantitative tools, but as you interact with colleagues, with clients, and we don't call them patients, we call them clients. Say no one really wants to be a patient, but they like being a client. We also have a real focus on education. So you can look at all the data, and there may be 2 or 3 people who can interpret it, but in order to communicate it to your client and to your colleagues, we use more of a subjective or qualitative system called Silicon Coach. And you've probably heard of Dartfish. It's another type of program that you can, or annual subscription that you can use. And so we sit down with each client, and when we describe to them what we see in the data and the interpretation of the data, we also support it with this. So it's interesting how many people have never actually watched themselves walk or run. And so if you're talking about what's happening at the pelvis that may be influencing their knee and may help to describe their mechanism of injury, it's very useful to have this up in front. And we used to use whiteboards and draw it on chalkboards and whatnot. Now we can show them dynamically, and with some simple, quick and dirty measurement tools, describe to them exactly what is occurring and how we're going to intervene. So it's just a tool that we use for education. So I thought what I'd do is just show you a few examples of some of the collaborative effort that goes on. And what we're really trying to do is work together. And most of this group that I work with were provided the medical services for Vancouver 2010 when we had the Olympics. And learned from that experience, and it was probably very similar to what happened here in London, of how valuable it is to work collaboratively, to work as a team, rather than have people move around from clinic to see various professions. So what the lab really has become, I think, is a source of referrals internally to get information about some of the underlying mechanisms or cause of injury, but also to look at and validate the interventions that we're using. So one of our goals is to say, okay, we see this pattern of movement, we intervene with some exercise program, we want to retest over time to make sure that that intervention is in fact working long term. So part of the role is more of a diagnostic, I think, as you described, or to provide more information to help inform interventions, and then part of the role is really to validate interventions. So I'll show you a few case studies, and I picked a few of my favorites. We've seen about 250 individuals this first year, and it ranges. We've had our top marathoners, Triathlon Canada in, and we've had the guy who wants to walk his dog 3 times a week. I had one lady come in a few months back. She wanted to do Zumba. So there's a huge continuum. The math is the same, the calculations are the same. And we take a slightly different look where we actually treat everybody as a single subject design. We look at that person and we look at them longitudinally, before and after some intervention. And so it's been a lot of fun. So this first one is a 48-year-old mother. She had a couple of kids, used to be a runner, and took about a 15-year break to look after her kids and really wanted to get back into running. And if you haven't been to Vancouver, there's a lot of runners there. It's a very high population. We have a 10K event every year called the Vancouver Sun Run, which has about 50,000 participants, one of the largest 10Ks in the world apparently. And her goal was to get back to the Vancouver Sun Run. And we have these programs in Vancouver called walk-run programs. I'm sure you have them here as well. Sort of a periodized program to return people to running programs, where you intersperse bouts of walking and running on each training session. So she wanted to get back into a clinic and participate in this 10K. And she was referred to us from sports medicine with right side patellar tendinosis and also with tibialis posterior pain. So what we did was we wanted to look at her walking and we wanted to have a look at her running. And the reason is that oftentimes you'll see certain movement patterns in a walking task, but they don't exist in running. So you can see very different dynamics when somebody's running. So we'll collect more data and be able to compare the two conditions. So here she is, and at that time, and it was quite interesting, and I'll talk about this a little bit more as she gets going, but just walking, she was pain-free, and once she got running, she was comfortable for the data collection. As we ran her a longer duration, she started to feel her symptoms. So we're always trying to capture data under pain-free conditions so that we know what we're looking at. We have clean data. We don't like to see people in an acute stage because you're not really sure what you're looking at. But she ran for us, and right away I could see that there was something going on with her pelvis. So a lot of this you can see visually. But as Trevor mentioned, there's things happening in the transverse plane that are very hard to see with the eye, and nobody but Yoda can see the force. So we measure the forces, and I believe that it's the forces that cause injury, and the kinematics don't always correlate with the forces that you see. So you have to be careful with that. So from our analysis, what we discovered was that she had an upward rotation of her pelvis on the right side. So currently, we are looking really from the pelvis distal to the foot. And we're building an upper body model right now, and you need to have more. We have enough cameras for that. There's a lot of important information, particularly in the triathlete, in the upper body as well. So we're building that out currently. But right now, we look at people from the pelvis down. So we look at how they rotate in the frontal plane, okay, like you're looking from the front to the back, from the transverse plane, if you're looking down from the ceiling, and then from the side, the sagittal plane, forward, backward rotation. So she was up on her right side and showed greater excursion. So that's the obliquity that you see when the person's running. There's more movement on the right pelvis than there was the left. And in the transverse plane, she was back slightly, about 5 degrees on her left side. So right away, you know that that's going to affect the hip angles and the hip forces. So pelvic asymmetries are critical to trying to figure out each of these clients. And I really treat the lower extremity as if it's sandwiched in between the center of mass and the ground. For years, we've paid a lot of attention to what the ground does, and what the foot does affects everything up the chain. There's growing evidence and strong evidence that it's a combination of that plus forces and energy traveling proximal to distal from the center of mass downward. So I really treat the lower extremity like it's sandwiched. And so the pelvis right away we see an asymmetry, and we'll likely see some asymmetries in the hips and then the knee. So at initial contact, she showed greater hip adduction and internal rotation on her left side. If you look at the knee flexion angle, initial contact was lesser, both at mid-stance and at initial contact on her right side. And she exhibited, and this is some of the sweet information, she exhibited less negative joint power or eccentric work in her right side quadriceps. So because we have the kinetics, we're able to do calculations around the joint powers. And the power is the product of the moment, or the torque, times the velocity. And that gives us some great information about eccentric work and concentric work of muscle groups about joints. And in her case, she showed decreased joint powers on that right side, where she's having the patellofemoral problems. So the kinetics can give you some great information about muscle function and dysfunction. And then she showed a greater knee abduction moment on her right side. An increased knee abduction moments, that's the internal joint moment, has been shown to be associated with or causative for patellofemoral problems. So Doug, these are the only graphs in this talk, because Doug doesn't like graphs. He says podiatrists really don't like graphs, right? He's embarrassed me many times. This is just to explain to you what I mean by joint powers. So the far left, you have the knee joint angle during the stance phase. So the knee is slightly flexed, typically when they hit the ground, a rear foot striker. It rapidly flexes to approximately mid-stance and then extends to toe off. There's a moment produced about the knee in the sagittal plane to resist that angular rotation of flexion extension called the knee extension moment, and that's in the middle. Okay? So this is produced primarily by your quadriceps. And if you take the slope of this line, the velocity, you multiply it by the moment, you get powers. And the power negative phase is eccentric work done by those muscle groups. The positive is propulsive or positive concentric work. So this is her data. She showed less power there on the negative power absorption on the right side. The knee abduction moment has been written about a great deal recently. As the runner goes into mid-stance, typically the knee goes into more varum or adduction, and that is resisted internally by the knee abduction moment. And Darren Stefanishin's done some really great work at Calgary looking at prospective studies looking at individuals with patellofemoral problems and iliotibial band syndrome typically have greater knee abduction moments. So we saw this on the right side of this lady. At the foot and ankle, there was decreased dorsiflexion on the right side. And we can also measure dynamic stiffness with our system, which is kind of a pseudo-stiffness measure. But passively on the table, you guys will every day look at people's range of motion at the ankle. We do it so we can do it dynamically. And we look at the hip, knee, and the ankle in the sagittal plane. And she exhibited greater stiffness on her right side. In the frontal plane, she exhibited greater rear foot eversion angles, velocities, and there was a decreased ankle inversion moment produced on the right side. So the ankle inversion moment is the moment that's produced primarily by tibialis posterior to resist pronation or eversion. So when we see asymmetric production of that moment, we often suspect that the individual needs to work on strengthening the tibialis posterior. Much of Kulig's work focused on that. So that's what we saw. We also saw some differences in ground reaction forces, the magnitudes for the impact peak and loading rate, which are often associated with patellofemoral pain, stress fractures, were greater on the right. And she tended to have greater dorsiflexion on that right side when she hit the ground. So she exhibited a greater rear foot strike pattern on that side. Now the key, though, and we're going to talk about this a lot tomorrow, is her stride frequency was measured at 145 to 150 steps per minute. In most runners, and I'm going to show you some data and research tomorrow, but in most runners, the goal for most competitive runners is to run at a cadence or stride frequency of about 180 steps per minute. That means your right side hits the ground 90 times per minute, your left side hits the ground 90 times per minute. And when you see the lesser stride frequency or the lower cadence, often you'll see greater moments at each of the joints, particularly the knee and the hip, and particularly those moments that are associated with injury. So we knew we needed to do some work with her on running style. So the collaborative opportunity here was really with 3 or 4 different areas of the Institute. And so what I do is I look at the data, interpret the data, write a full report, and then I provide each client with 3 or 4 or 5 things to work on. And these aren't referrals, these are recommendations. So I educate and say, these are the things that I think, based on my experience, might help you. And so with her, she had foot orthoses that were toast and needed to be renewed, worked for years, and so we collaborated with Podiatry for that. We also worked with physiotherapy to have a functional assessment of her core, to try to figure out why there were those asymmetries we saw in the kinematics of her pelvis, because that obviously was affecting the hip, and particularly on the right side. Also, we asked that we worked with, to work with physio to look and assess the tibialis posterior and look at its strength and function, because we saw that asymmetry in the inversion moment. And then we worked together with this client on a few sessions of gait retraining, which I'm going to talk about more tomorrow, to try to increase her stride frequency. And it was interesting when we worked with her, because when she came in the second time, we had her run for a period of time at her preferred speed and her preferred cadence, and her knee started to bother her. And we put up a metronome in front of her and adjusted her stride frequency, kept speed constant. She just moved her feet a little bit faster. So going from this to this at the same speed. And she went asymptomatic, or the pain went away when we increased her stride frequency on the fly. So we worked with her over time so that she could go and do her event. And one of her main advances was just simply through adjusting her stride frequency. And then we had her use hydrotherapy in the interim to increase her fitness. So we have an underwater treadmill that we use for rehabilitating stress fractures, Achilles tendon ruptures, and also for individuals who are wanting to return to play and need to maintain their fitness in the interim while they're rehabbing. This takes away about 80% of body weight, we estimate, so they're able to exercise against resistance continuously while removing 80% of their body weight. Okay? So she did this for a little while just to get reconditioned before she went out on the road. And she went through her running clinic and did the Vancouver Sun Run successfully. So it was a nice story, and a wonderful lady. So often we really have 3 roles. One is injury management, so that's a good example of injury management, and a little bit of performance optimization, okay, helping somebody perform better. And performing might be a race, performing might be walking your dog, right? So everybody's performance is different, that's important to them. So we really focus on the goals. The other thing we're really keyed in on is injury prevention. And this is a good example of somebody who presented with an injury, and we actually discovered something that led to injury prevention measures. So this is a 14-year-old basketball player, female, and she came in with a right side navicular. They thought it was an accessory navicular. She had pain in the navicular area and along the insertion of the tib posterior on her right side. And her goal, and that's a question that we ask each client, is what is your goal? Was to return so that she could play. She was 14, playing senior high school basketball. She was probably 6'1", 6 feet anyway, and very good at her sport. So we started looking, at the foot and ankle first, and then worked our way up. And so for this case, we wanted to see what was going on within the foot. Putting a set of markers on the shoe, measuring the shoe motion wasn't sufficient. We wanted to look at the coupling between the hallux, the midfoot, and the rear foot, and in 3D. And that's what you can do with the multi-segment foot models. You can look at the coupling within the foot, and particularly what's happening at the first MTPJ. And then we had her do a run as well. Okay? So this is the setup for the multi-segment foot model. And many of you have probably heard plenty of lectures on this. Just at the top, there's a schematic of what we're trying to do. It's get more information about what's happening within the shoe from barefoot walking. And so we had her do the walk first. You can see her standing here. She's quite tall. You can't see her face. I had to take them all out. So she'd do a little walk for us first, and we collected on her. You can see a little bit of femoral internal rotation there. But we broke the foot down and we had a look at differences or asymmetries between right and left. And certainly from a kinetic point of view, she exhibited less ankle inversion moment on that right side or the affected side, which perhaps gives us some information about what's happening with tibialis posterior. And there was greater rear foot eversion and abduction, and the midfoot abduction was greater on the right. So there's your abduction of your midfoot on your rear foot. So then we had a run, and we thought, well, we should have a look. She's a basketball player, and what happens to a lot of 15-year-old basketball players, female in particular? They have a high frequency of non-contact ACL injuries. So we wanted to look at her hip and knee dynamics when she ran. And running basically is just landing from a controlled jump over and over and over again. So we could see, once we got her running, that there's definitely some interesting things going on with her knee. That dynamic valgus or knee abduction that occurs often from landing from a jump shot or from a cutting maneuver, we could see that in her running. So we wanted to make sure in her recommendations that we also looked after injury preventive measures as well. Okay? She had no history of prior ACL injury. So if you looked at that pelvis, there was great excursion, about twice as much as we typically like to see in a runner at their preferred speed. Her right side was backward in the transverse plane, about 4 to 5 degrees. At initial contact, she exhibited greater hip adduction and internal rotation on her right side, which is typical of many overuse running injuries, as well as people who are at risk for ACL injury. And she exhibited a greater knee abduction moment on the right side. If you watch her, if I could put this in slow motion for you, I would, but when we sit down with the client, we go to slow motion, we get to mid-stance, we show that contralateral pelvic drop that Trevor was commenting on. When they're in mid-stance, on their weight-bearing side, you look at the contralateral side, and if it drops down, we like about 3 or 4 degrees there, but she was showing about 6 to 7. So we got together with our podiatrist, and the strategy that we used with her was a standard Ritchie brace for training and for her gameplay initially, and then bilateral custom foot orthoses for day-to-day. And this she responded great to. Her dad still, he's sent some lovely emails to us thanking us. We also, though, needed physiotherapy, and we needed to really work on core strengthening and working on the strength of those muscles about the hip and through the abs to really tighten up that pelvis. And also we recommended some gait retraining for her. Her cadence was very low. And then she also did some foot adduction exercises as per Kulig's work, trying to strengthen the tib posterior eccentrically and concentrically. Okay. So I'm gonna. How are we doing for time?
Lunchtime.
Lunchtime. Okay. I'm gonna skip this one. I'm gonna go to this last one because he's a great story. So this last guy, it's just about 2 or 3 minutes. This guy's 60 years old, has run for 30 years, and when you're around runners, you realize how passionate they are about it. And for some people, it's a major part of their lifestyle. So this guy comes in, and he's been just diagnosed with early medial compartment OA in his knees, both sides. And he looked at me and he said, I just want to be able to continue running. He goes, I need it. I'm an accountant. And he said, I need some time away from my wife. He did say that. So he was relying on this in a big way. So he brought her in for the follow-up, and she was really quite beautiful and lovely. Anyhow, I don't know. Anyway, he's an accountant. I think that was the big deal. So he came in. He goes, is there anything we can do so that I can continue to run? And I said, well, let's have a look. And if not, we can get you in an active walking program. And we'll talk about walkers a bit more tomorrow. But his goal was to return to run. And this guy was passionate and was really kind of upset that he couldn't continue on. So we had a look at him while he ran at his preferred speed. We typically look at everybody at their preferred speed. If we're dealing with somebody competitive, we'll also look at increased speed and more closer to race pace speed, so we can duplicate what happens in the competitive sense. But for the most time, we look at people's preferred speed. So he had his right pelvis was upward and backward, so upward in the frontal plane, backward in the transverse plane, about 5 degrees. He had marked sagittal plane and frontal plane excursion. So there was, his right side was up, but both sides were moving quite a bit. He had decreased hip flexion at initial impact. So with bony type injuries, or when you're looking at osteoarthritis, your strategy really is to decrease the forces at the joints. And so I looked at people's natural mechanisms to attenuate force. So eversion of the ankle, knee flexion, hip flexion, and the coupling of those three. So he had less hip flexion than optimal, and he had decreased hip adduction and internal rotation on his left side. So there's some things going on at the pelvis. He also showed decreased knee flexion at initial contact. So there's kind of an optimal amount of degrees when you hit the ground in order for you to attenuate force effectively. And that was basically his knees were too extended. And he had decreased rear foot eversion velocity bilaterally. So we look for an optimal amount of rear foot eversion velocity, the degree, and the excursion. So what I surmised from this was, okay, we have to figure out ways to help this guy attenuate force if he's going to do anything. Because right now he's stiff as a board when he's running. And his stride frequency was at 150 steps per minute, which is what you'll typically see in the recreational runner until they work on it. If you talk to track and field coaches, triathlete coaches, anybody that's been in the business for a while, they'll tell you, well, yeah, 180 steps per minute is kind of the number that the competitive runner shoots for typically, and most of them maintain that or greater. And it just hasn't trickled down really to the recreational runner, I don't think. So we had a look at that. So here he is, trucking along. And so immediately on the fly here, I pulled out a metronome on an iTunes application. So they're really easy to get now. And I was clapping next to him to try to get him to increase his stride frequency. And just immediately he felt better. So it's a very simple thing. And we're going to talk about some tricks about this tomorrow. But he just increased his stride frequency, and he went on to also see physiotherapy to have a look at his pelvic and hip function. We measured a potential, careful on how I say it, leg length discrepancy. So we look at the distance between marker positions, left and right, from the pelvis down to try to pick off leg length differences. And we see a lot of people who in quiet stance exhibit a leg length difference that does not resolve when they become dynamic. So you'll see it in quiet stance, you'll see it when they run. We also see lots of individuals whose pelvis is quite level and statically, but once they get running, they exhibit a functional leg length difference. So we're always looking at that too and passing that on to either the physiotherapist or collaborating physician. This gentleman had rigid foot orthoses, and we made a decision to take those foot orthoses and make them more of an impact design for his running so that he had better shock attenuation. And then we worked with him to get his stride frequency increased by about 10%, just to start. And he was just shuffling along. He stopped doing these big strides, and he just moved much smoother and much more comfortable. So we'll talk about that tomorrow. Thank you, everybody.